welcome back. Um, Thanks for listening to these or watching these series of video instructions. Um, so now I'm going to be going into talking about medication-assisted pharmacotherapy and the use of and also other treatments for substance use disorder and evidence-based treatments for substance use disorder. So let me get the slide going here. We shall begin. Okay, medication-assisted pharmacotherapy for withdrawal. So we're going to talk about the medications we can use for different withdrawal symptoms that we talked about in the first lecture. So probably the one that we is getting a lot of press, and we think about in here in certainly in Sacramento for the past year or so, with a lot of trainings and interventions with with our local emergency rooms, and also adoption by our major Medi-Cal health plans, which expanded the access to it, is buprenorphine. And buprenorphine is, it's an interesting molecule. It's technically an opiate, but it's an agonist-antagonist. And so what this means is that at certain doses, it can act like a pain medication. And then at higher doses, or when in the environment with other opiates, it can actually block the action of an opiate. And so it can be used to treat both withdrawal and cravings, and is an effective opiate replacement medication that, unlike methadone, you can use in a primary care setting or a general psychiatric setting, as long as the person prescribing the medication, as long as the either the psychiatrist or nurse practitioner or family medicine doctor or internist, as long as they've gone through the training and have the special DEA, they can prescribe this medication. So, and typically it's used to treat non-complicated opiate withdrawal. Nowadays, a lot of times we do it at home, but you may get the first dose or two in the office. And then after that, we can use in the maintenance phase to help reduce going back to more dangerous types of opiates like heroin or Norco or morphine or fentanyl. Typically you use 8 to 16 milligrams when you start it, and then you try to titrate down to a maintenance dose for the person. It has a long half-life, so a lot of times you can give it once or twice a day. It does require that you take it sublingually, and so sometimes that takes a training with the patient, or it really taking time to make sure, especially if there's cultural, language, intellectual functioning problems, that you make sure that you they understand that they have to let the agent diagnose, kind of reply under their tongue, in order. Sorry, my dogs are going crazy. Apologize for that. And so anyways, it's sublingual, whether it's a tablet or a film. But what's good is there's also an intramuscular once a month, intermuscular. There's several month, subcutaneous application. So we have a lot more options with dosing once you get the person through the first initial induction. So the phases of buprenorphine treatment is the induction phase, or basically the acute withdrawal. So, giving them, first starting them on the buprenorphine medication. Usually what happens is they come in acute withdrawal. When it comes to heroin or Norco, it usually just takes a few hours, or somewhere between 12 and 24 hours, and they'll have a pretty high clinical opiate withdrawal scale, and you give them the medications. You know, if they're in like partial withdrawal, so if they have used, you know, a little close to the induction phase, it may drive them into full-blown withdrawal. So you just have to be prepared for that, and make sure the patient understands that as well. Even with that said, there are, you know, years of really good data, even in the homeless population, that people can safely do most of their induction at home, you know, lying on the couch or whatever. And so, especially with telemedicine and the era of the coronavirus, we can still use buprenorphine pretty safely. Then you have the stabilization phase. And so that's where, you know, this is where you really want to work on your behavioral interventions, getting them going to NA, getting connected to groups, trying to address whatever other psychosocial issues that might have been contributing to their drug use, to try and build them up so that they have the skill set. Now that you kind of, you know, broke the cycle of the opiate, you know, abuse or use, you know, you can try and build on that. And then eventually you get them to the maintenance phase. And this is where, you know, we need more research on, is like, you know, should we say should the goal be, you know, years to lifelong use of this? Like how long, when do we know that we want to, you know, when's the adequate time, or how are there ways to assess somebody to say it's okay to have them stop using buprenorphine? In my experience, I think people naturally come to that. You know, I remember I took care of a patient who had a long problem with prescription drug abuse and on and off heroin, successfully inducted her. She was on for about 2 or 3 years of methadone. And then she started college, and she just, you know, it wasn't like she had no side effects on it. She felt like it was making her a little drowsy. And so we kind of, over a few months, weaned her down, and eventually she stopped, and she's, you know, maintained sobriety. That's, you know, probably a good outlook. But some people who've had, you know, been using heroin for years and have had, you know, greater, you know, like more than 7 attempts at sobriety and none of them stick, you know, they may be somebody you want to think about, you know, essentially lifelong use, or at least the long-term use of the medication in the maintenance phase. So when do you know, a lot of times you have to think about like, well, when should you not use buprenorphine in the outpatient setting? I think, you know, in some ways you trust your gestalt on this. I mean, if the person is not, you know, 100% with the program, you know, you can't reach them very well. You know, they're late or missed several appointments. They may not be your best candidate for this. And then also those who are very complicated. So either complicated with medical problems, maybe they, you know, some of the more complicated patients are those who have, you know, legitimate pain problems, or a lot of comorbid medical problems that you may want to watch them for, you know, effects on sedation or side effects a little more closely. And then those who may have a lot of comorbid psychiatric problems on top of it. So they have like severe bipolar disorder or borderline personality disorder, or schizophrenia, and you know, you know, so they need more specialized care, and they may do better in an inpatient detox facility or dual diagnosis facility. For alcohol and benzodiazepine withdrawal, so, you know, the gold standard is benzodiazepine. Even for benzodiazepines, it's a longer half-life one, typically like Transine or lorazepam, and you know, but, you know, especially if somebody is not responding. So I have seen a few scenarios where the person has such severe withdrawal and seizures they're not responding to benzodiazepines, and you can use pharmaceutical grade ethanol for severe withdrawal as well. There are some other medications you can add. So you can add anti-epileptic medications. This is something that's evolved and has, really, I think, helped reduce the morbidity and mortality from alcohol and benzodiazepine withdrawal. So Depakote, carbamazepine, I've seen topiramate, lamotrigine. You can also use medicines that downregulate glutamate, because again, when you're going in withdrawal, you can have these glutamate storms that can cause a delirium or encephalopathy. And so clonidine and propranolol can also be used, especially if they're having a lot of tachycardia, very, very high blood pressures. You can use clonidine as well. You can also not use a benzo. And I train my residents and physicians I work with to really think about, if somebody just has like mild alcohol withdrawal and they don't have a history of complicated withdrawal, and especially if they're young, try to actually use a combination of valproic acid, carbamazepine, gabapentin, baclofen. Try to use non-benzodiazepine agents, because there is some data that shows that if you can treat an alcohol or benzodiazepine withdrawal with a non-benzodiazepine, something other than benzodiazepine, that they're more likely to be sober 6 months down the line. And part of the problem is like when you're using a benzodiazepine to treat benzodiazepine withdrawal, you're just sort of kicking the can down the road, essentially. And they're still going to have problems with cravings and issues with that's been driven by tolerance down the line. So you can use gabapentin. It doesn't have an FDA indication, but there's plenty of studies showing that it's helpful for both withdrawal and also maybe maintenance therapy, especially for mild to moderate alcohol use disorders. There's a wide range in doses. You kind of dose to the how they to a symptom outcome that you're looking for. But they're a great adjunct, a non-benzo adjunct. It's very handy in the primary care setting where you might have somebody who you're just trying to help them get off of the benzodiazepine, and they don't really have like a severe, they're not on a super high dose, but they're having some symptoms. You can use gabapentin in that case. Baclofen is also helpful for benzodiazepine withdrawal. There are some increasing studies using ketamine, both for withdrawal and also for maintenance with alcohol use. Doesn't have an FDA indication, I think, but I think there's enough data out there that if someone's failed other treatments, to consider its use. Now for MAT pharmacotherapy for cravings and other substance use disorders. So, buprenorphine can be used for cravings, like we said before. Methadone is used particularly for opiate cravings to reduce rates of opiate reuse or relapse. In many ways, methadone is the gold standard. We have, what is this, we have nearly 50 years of data on its use. The problem with methadone, I think, is that especially with an older population, there's a degree of cardiotoxicity. You really have to monitor these patients for QTc prolongation. If they relapse and they still have methadone in their system, it doesn't have that safety aspect, that agonist aspect that buprenorphine has. And so you can see some pretty tragic, unintentional overdoses with somebody who, thinks, they stop methadone for a week and they think it's okay to go back on heroin or whatever, but they still have a significant amount of methadone in their system. They just don't realize it. For alcohol and benzodiazepine cravings, or to reduce risk of relapse, you can use acamprosate and naltrexone. Naltrexone there's more and more data that you can actually use naltrexone for the withdrawal symptoms as well. So a lot of times with patients who are going through alcohol or benzodiazepine withdrawal, I will start them on naltrexone, right off the bat. As soon as they're ready, they want to change, and they start going to AA meetings, or they want to stop drinking alcohol, I'll add naltrexone pretty quickly into it. There's less data of that with acamprosate. I prefer naltrexone because it's a once-a-day drug. You have an option for a long-acting injection. Acamprosate is a pretty short half-life, and so you have to take it 3 times a day, and it has a little bit more side effects it's not as well tolerated. However, you may run into somebody who has like a lot of liver disease, or they just didn't tolerate naltrexone, and so acamprosate is not necessarily the wrong answer with that. And some of the medicines I talked about for the treatment of alcohol, and benzodiazepine withdrawal, you could also use for treating cravings and to try and help a person from not having a relapse back into overuse. And so gabapentin, topiramate, nalphenamine, valproic acid, vigabatrin, and baclofen. Now here I'm going to get to some of the bad news, or at least not so much good news, for medications for amphetamines and methamphetamine. And right now, there are some randomized control trials you might have seen with like mirtazapine. I do know that there are some trials going on using other amphetamines as sort of an amphetamine replacement therapy, so to speak. But really, if you're for cocaine and other stimulants, methamphetamine, prescribed stimulants, there really isn't a good medication for it. So for now, I can't really recommend a particular medication. That said, if there is an underlying condition that may be driving the use to some degree, untreated schizophrenia, untreated bipolar disorder, certainly you want to flush that out and treat that, because if that's better controlled, then they may have a better leverage into reducing their methamphetamine use. There are also some on the interventional psychiatry wing. There are some interesting studies looking at RTMS, transcranial magnetic therapy, particularly for stimulant or methamphetamine use disorder, that are very promising. But access is limited, especially in the Medi-Cal population. So this is sort of rehashing what I just said. There are some very good evidence-based behavioral interventions, though, particularly contingency management I think if one thing maybe the Alcohol and Drug Services want to really try to invest in and promote are in contingency management programs. These are controversial because kind of similar to harm reduction therapies, there are those who have especially those who may look at drug use and from a more moralistic, or this is a personal choice type of situation, may criticize contingency management as essentially rewarding people for bad behavior. But what contingency management is that people get a reward that's contingent on their getting certain milestones in their recovery. And you can do it. There's a couple of general approaches to it. Some use like a lottery and for a high value item, and every time they get to a step, they get more and more tickets in the lottery. Some have like less valuable things gradually going to more valuable things. But these are tangible rewards, like Starbucks cards or gift cards or cash. That but it's can be very, very effective in helping people change their behaviors. I kind of like it because it's more of it works on incentives as opposed to punitive or trying to control somebody. Maybe it's a different form of control. Maybe it's a more pleasant form of manipulation. But it definitely has good evidence. It was all over my last time I did my research for psychiatry. And it's probably the best studied and has the best evidence particularly for cocaine and stimulants. This is kind of the same what I said before. So contingency management, tangible rewards to reinforce positive behaviors such as abstinence. And the principles are values to rewarding consecutive negative drug tests, counseling sessions, attending, but they resets whenever you get a positive drug use or the unexcused absence. So, so people know what the contingency of their behaviors. So they are driving where they go in the program. So you can have voucher-based reinforcement or prize incentives based on a weighted drawing or lottery. So then I would have questions, I guess, at that point. So I'm going to switch slides really quickly. So let's see. Let's have a slide set here that make sure I covered everything. All right, start here. Okay, so other evidence-based approaches that are not medications for the treatment of substance use disorders. So we talked about contingency management. Another skill set that's really important, and hopefully we can figure out a way to do this with Marty Lehman to record a session with him, or Shelley Henderson. She's a psychologist at UC Davis who is very good at teaching motivational interviewing. And motivational interviewing is both an intervention, and to me, it's also a philosophical approach of trying to understand where the person is in their own recovery. And it can not only be helpful in substance use, but it's very helpful in psychiatry where, adherence to medication is really, really important. It's really helpful in a lot of primary care, especially metabolic disorders like diabetes, hyperlipidemia, cardiovascular disease, hypertension, because the person is the most important. The person being treated is actually the most important part of the treatment plan because they have to act it out. So learning motivational interviewing is really, really important. 12-step, I go back and forth on it, but unfortunately, it's what we have. The data itself for the efficacy of 12-step programs are pretty bad, but anecdotally, I've had enough patients tell me that they at least get something from it, and it's free, and they can get to a meeting that I still encourage patients to utilize it if they find it helpful. If it doesn't work, doesn't really affect my treatment of them or how I work with them. Problems with 12-step, it's religious based. Some of the 12-step programs are very anti-medicine, and so especially like buprenorphine and things like that, the patients may get conflicting messages that can impact their adherence to it. And again, like I said, the data is pretty poor on how efficacious it is. This is a couple of slides on motivational interviewing. Probably most important thing to remember is the ORs. So key part of motivational interviewing is open questions, affirmations, reflections, summaries. So these are just ways to improve your communication. And this actual kind of heuristics of trying to understand someone can help you in any part of medicine, in my mind. Like, you always want to open questions. You want patients to elaborate and give you information as opposed to you trying to infer that information from them. You want to make sure that the person, when they're doing, you want to foster that they're talking to you as positive. So you want to affirm, and also you want to support them. So people coming to talk to you with a substance use disorder, oftentimes they have low self-esteem, and so they need some affirmations. Reflections and summaries are really important to make sure that you understand what's going on with them. So these are techniques to make sure that the process of them, hearing what you said. So if you want to think about how complicated a simple discussion is. So you see a person in front of you and you want to start a conversation on something. And so you have an idea in your mind, then a part of your brain has to translate that idea into a sentence. Then that sentence has to be translated into you articulating that through spoken language. Then that person has to hear what you said, translate that into into their brain, translate these sound waves into language, and then they have to translate that into a thought or a concept. So there's a lot of areas where you can have a breakdown in communication. That you see this all the time on Facebook, unfortunately. So anyways, the reflections and summary parts helps reduce that error, because it builds into the process of interviewing somebody. You taking the time to say, like, let me make sure I understand this. You've told me X, Y, and Z about your alcohol use. And you summarize it and you say, is that correct? And this is what I heard, you're telling the patient. Did I hear it correctly? And then the patient has an opportunity to contribute to that. And that, to me, it kind of levels the playing field, but also conveys a sense of respect, that you're really interested in what the patient is saying to you. Motivational interviewing training also is really important in your own, as a healthcare provider or mental health care provider working with people with substance use problems. I mean, it can be very stressful. It helps you develop your own empathy. It helps you deal with all the resistances. So I think it also helps you as a provider with your own health, kind of dealing with the stress of treating these patients. And then, so that's a little, I've already talked about contingency management, some more. So I think that's about all I can say right now for treatment. Like I said, this is just a kind of an overview. If you have any questions or other areas you want to talk about, or cases, please let us know, and then I'll try to make another one of these lectures on it. Thank you again.